Hi, I'm Kathy Miller, and I'm from the nursing programs at Grand Rapids Community College. I'm a faculty in those programs, and I'm here to have a conversation with Shannon Brownlee. And welcome, Shannon, to Grand Rapids Community College. Shannon is a journalist and has a background in science as well. So she has written a book, Overrated, which was very interesting. So Shannon, why don't you tell us a little bit about your background and how you got to where you are in your career?
I was trained in basic science. I have a master's in marine science, and I did field work as a graduate student. And I wrote about basic science, and I wrote about space science and evolutionary biology and molecular biology and all kinds of things for a science magazine called Discover, and then went on to write for U.S. News and World Report, and I wrote about medicine. And I wrote about biomedical research, a lot of the research that's going on at the NIH. And I started to get interested in healthcare policy and the intersection between how we pay for care, how care is actually delivered, and what kind of care we get in this country, and whether it's any good. Because I stumbled upon a story about a treatment for breast cancer, and it was a pretty extraordinary story that's now been fairly widely reported. But it was a breast cancer treatment that was used for 20 years and turned out to actually not be any better than standard treatment. But it was much more. It was a deadly treatment. It killed a lot of women. So I got really interested in why medicine would grasp hold of something without having evidence that it actually worked. And I discovered that, in fact, a great deal of medicine doesn't have a lot of science behind it.
Yeah, that's kind of a scary thought.
It is a scary thought.
I've been in healthcare all my adult life, and have witnessed some of that less than wonderful aspects of healthcare as well. When I was reviewing your book, one of the things that jumped out at me was the profit piece of hospitals. And hospitals do need to make a profit to survive.
Sure.
So how do you see that profit making? How will that change if we do less and still give the same amount of care?
That's a very, very good question. And as I was reporting Overtreated, all these connections between how we pay for care, what the science is, what physicians think, what patients want, malpractice, there were all these forces that all come together and end up kind of driving everybody in the same direction, which is to give more care, not necessarily better care. Mm-hmm. And one of those forces is how we pay hospitals, and the fact that hospitals need to make money to survive. There's a saying in hospitals that I'm sure you've heard that goes back to the days when most hospitals were actually run by religious groups, which was no margin, no mission, which is if you don't make any money, you cannot fulfill your mission, which is to take care of all comers, to care for the population around you. So hospitals make money in a number of ways. They lose money in a number of ways as well. One of the ways they lose money is that they take care of a certain number of people who don't have insurance. And this is a real problem in this country, where we have 47 million people who don't have adequate health insurance. So one of the ways that hospitals make money is by focusing on the most profitable aspects of the care that they deliver. And those turn out to be the high-tech things. So they don't make money when you come in with pneumonia, and they do make money when you come in with a heart condition. They make money when they do neurosurgery. They make money on orthopedic surgery. They make money on CT scans. In fact, one of the fastest rising costs in our healthcare system, and one of the most profitable departments in any hospital, is radiology. So if we continue, this statistic really blew me away when I ran across it. If we continue at the same rate of increase that we are now, in a year we will be doing 300 million CT scans a year. That's a CT scan, averaged out across the population. That's a CT scan for every third person. Now, obviously, I haven't had a CT scan this year, and a lot of people haven't had a CT scan this year, which means that a whole lot of other people are having a lot of CT scans. And so hospitals have this built-in need to give people CT scans because that's one of the places where they're making money.
Yeah, so what do you think will replace that money making in a hospital if they begin to reduce the amount of the profitable practices that they have?
Well, this is the problem with doing something like controlling price per unit of service. So let's say Medicare said, okay, we're not going to pay as much per CT scan because that, we know that you guys are doing a lot of CT scans that are unnecessary. We're going broke overpaying for CT scans, and we're just going to reduce the price per CT scan. Hospitals and physicians have two responses to that. It's almost like squeezing a water balloon at one end and it bulges out at the other end. So what happens is you either increase the number of CT scans you do to make up for your lost income per unit, so you just do more units, which is what any business does, or you find a different arena. You find another area that's more profitable to be able to keep up your income. And part of the problem is that until very recently, we haven't really focused on the fact that a lot of what's being done is unnecessary, that it is not leading to better care. So without focusing on that, all the actors, all the providers in the system have sort of been moving from profit area to profit area to profit area without really grasping that they're delivering an enormous amount of care that isn't helping patients. And I don't believe most physicians or nurses or hospital executives are sitting there rubbing their hands together saying, how can we bilk the system? How can we give people care they don't need in order to make more money? It's being done very unconsciously.
I think, do you think it's also driven by the patients or the consumers themselves? As the patients that, I see or interact with are certainly much better prepared to be patients. They Google their illness or their treatment plan, and they come in to the hospital or to a practitioner and say, this is what I would like, what I think I need, this is what's best.
Sure. Patient demand is the term. And certainly patients do demand things. I mean, mom comes in, her son has fallen off the couch and bumped his head on the carpet, and she comes in and the child is examined and there's no neurological evidence of any kind of problem. And mom says, I want a CT scan because I know my kid needs a CT scan. Now, not knowing that there's a lot of radiation in a CT scan, certainly patient demand is an issue. But what we know is that there is tremendous variation in the amount of care patients get in different parts of the country. So the Dartmouth Atlas Project has been looking at this sort of variation around the country for the last 30 years. And what they have found is that there are certain areas, certain regions of the country that tend to deliver more unnecessary care than others. Now, and the difference is enormous. So if you look at the regional level, you see a 2.5-fold difference between how much care patients in, say, Minneapolis get versus how much care patients in Miami get. And these are basically the same patients. 2.5 times. If you look at individual academic medical centers, there is a 4-fold range. So NYU Medical Center, same patient is giving those patients 4 times the amount of care that an academic medical center, say UCSF in San Francisco. If it is not differences in how sick patients are and what they really need, what's driving those differences? Can it really be patient demand? Are patients in New York and Miami and Los Angeles and Detroit and Boston 4 times more demanding than patients in San Francisco or Salt Lake or Minneapolis? It's pretty hard to believe that that's what's driving it. It's something else that's driving it. And what it looks like, part of what's driving it is the supply of medical resources in these places. There's more doctors, there's more beds, there's more CT scanners, there's more ICU beds. And that seems to push the system towards giving more and more and more care.
Mm-hmm.
So yes, patients come in and they're demanding, and a lot of what they demand is pretty useless. Sometimes they come in and demand stuff they really need. But we can't lay it all on patients.
Oh, certainly not. Certainly not. I know one of the things you talked about last evening was the small number of primary care physicians that are in practice. How do you foresee bumping that number up?
Well, we absolutely have to. We've seen this terrible decline in the number of primary care physicians. And all the evidence says that communities that have a robust primary care system are healthier. We know this from repeated studies. So what we have to do is we need to change the payment structure. Right now we pay, if you get poked, the doctor gets paid more. If you get cut open, the doctor gets paid more. If you go in and talk to your doctor, and your doctor is doing this very complex process of really managing your care. If you have a chronic illness, for example, you have diabetes, your doctor needs to keep track of your blood sugar, your doctor needs to keep track of your heart, your doctor needs to make sure you're getting your eye exams, et cetera, et cetera. That doctor doesn't get paid very much. And that's precisely the doctor who is most important to your health. So we need to pay primary care physicians more. We also need to make it more attractive for young medical students to go into primary care. And there are two things that have to happen. One, we need to pay them more and help them with their debt that they come out of medical school with. And I think the other thing is prestige. There's a very interesting sort of hierarchy in medical school where the pediatric cardiologist or the pediatric cardiothoracic surgeon is the most exalted, the most super sub specialized, has the greatest prestige, and the family practice doc is at the bottom. And that's not the way it should be. The family practice doc should be considered the diagnostician, the person who really adds value in the system. That person should get more prestige. And I don't know how we change that.
And that's not limited to, physician practice either. I see it in nursing practice.
Oh, you bet.
The intensive care nurse is
certainly
is regarded, and
and
the nurse who cares for, the generic med-surg patient, or heaven forbid, long-term care.
Right.
Is really at the bottom of the pile. Or if you work in a institution that has lots of bells and whistles, or if you work in a little rural hospital that has 12 acute care beds,
right.
Much difference in how you are thought of as a practitioner.
That's right.
Absolutely. So I think it's pretty universal in healthcare, whether you are a physician or a nurse or an X-ray technician or whatever. So there are some real challenges in the future for survival of our healthcare, or good survival of our healthcare.
The biggest challenge right now is money. We're bankrupting our country. Healthcare is the single most important fiscal challenge this country faces. Right now it seems like it's the banking industry and Wall Street. But in fact, long term, the cost of healthcare is going to bankrupt us. And we have to get a grip on it. And so, these changes like increasing the number of primary care physicians, in fact, what we really need to do is change the ratio. We need to increase the number of primary care physicians and decrease the number of specialists. We need to get a grip on these places in the country where costs are going up faster than they are in the rest of the country, because the care is very chaotic and there's enormous amounts of unnecessary care that are being delivered. We need to basically find a way to get those places to change the way they deliver care. And somehow we have to get a grip on the cost problem.
In your talk last evening, you talked about some practices around the country that do that. Are there ways that they can take that knowledge and the experience they've had in developing those and apply it to other healthcare groups?
Yes, these are these organized group practices, and we know a lot of their names: the Mayo Clinic, Kaiser Permanente in California, Group Health of Puget Sound, the Geisinger system in Pennsylvania. These clinics exist all around the country, and they really do a better job. They are higher quality care. they have better outcomes in some cases, and they do it for less money. And we should be looking to these systems. And in fact, it's interesting because healthcare policy, people have known this for a long time. If you go back to the Clinton debacle of healthcare, they knew back then that these systems were real models of good care. And what the managed care movement was supposed to be was to transform the rest of the system and encourage this kind of organized practice. But what managed care really ended up doing was managing money. It didn't really get physicians to start coming together in these groups and organizing the way they did things, cooperating with hospitals. It just made everybody mad and squeezed the system a little bit. Kept prices controlled for a while, kept costs controlled for a while. So we have to re-recognize the importance of these systems as models. And hospitals and physicians have to start making the change. Now, hospital administrators and physicians will tell you, well, we can't make that change until the payment system is changed because we don't want to lose any money. Well, they can wait until the payment system is changed, or they can take a leadership position and really start doing what's necessary now. To wait until everything is perfect and to say, oh, we don't have to make any changes until, that we're going to get paid to do it, is, I think, to fail to grasp this moment and really start to make the changes that are necessary. Mm-hmm.
There are a lot of egos involved in that process,
A lot of money, too.
And a lot of money. Your book also challenges, I think, the consumer to take a stand as well. What do you think would be the biggest takeaway you would want someone to have after reviewing your book?
I think, the takeaway really is when it comes to medicine, sometimes less is more. That mostly that all of medicine involves trade-offs, and that we've tended to see medicine as this sort of unbroken string of advances. And that more and more and more medicine means we live longer and better lives, and that there's no downside. But in fact, there are downsides to everything. There are risks involved in everything that you can do. Going into the hospital is a risky thing to do.
Oh.
I mean, I didn't talk last night about the fact that patient safety is an enormous problem. The estimate is that 50 to 100,000 Americans die each year from avoidable medical error. That makes error one of the leading causes of death in this country. So we're worried about dying of breast cancer. We're worried about dying of heart disease. And meanwhile, medicine is killing a huge number of people. So we have to recognize that there is a trade-off every time you say, I want to go into the hospital to get this or that procedure. That's one thing that patients need to understand. The other thing they need to understand is that the amount of care that they get, that more care is not necessarily going to be better care. Better organized care is better care. And so these systems that have often been denigrated, I mean, we think of the Mayo Clinic as being this really wonderful place, but you hear people talk about Kaiser and they say, oh, Kaiser's so bad. Kaiser's really good. If we had a Kaiser where I lived, I'd go to it. Kaiser is terrific. But people get this idea that, I don't want to have anybody managing what's going on, and I want to be able to choose whichever doctor I want to go to. I want to be able to go to the cardiologist when I feel a little flutter in my chest. Well, what you need to understand is that what you ought to be doing is going to your primary care doctor. That your primary care doctor has to be the person who is really watching everything that's happening to you, that's keeping track of all the drugs you take, that's keeping track of when you're hospitalized, making sure that if you are hospitalized and you get out of the hospital, that you get the kind of care that you need. We think that choice is the most important thing in medicine, and in fact, it's not. So if you want good care, go to an organized practice.
Right, that primary care physician is
key.
Definitely the key to, good health care and living better, throughout your lifetime. Absolutely. You mentioned also last evening about hospitalists, and that's becoming a bigger part of healthcare practice as well. Do you see that as a disadvantage or an advantage for healthcare?
You know, the data are really mixed on hospitalists. It's not really clear that they improve care. They may not. I mean, they were sort of the hospital's answer to the fact that primary care doctors couldn't come in, and they were also hospital's answer to getting patients out of the hospital faster. So that's part of the job of a hospitalist, to get that patient out. When the Medicare payment is about to stop, you want the patient to go home. It's not clear that hospitalists have always truly improved care. They could, but it's not. I don't know that we know that answer yet.
And it's also another person in.
It's just another layer.
That's right, another layer who doesn't really know the individual patient as well as your primary care physician would know you. You know, that's.
The other problem is that there's a hierarchy within a hospital. And so whose patient are you is kind of always a bit of a question. And who's really in charge of your care? So if you go in for surgery, for example, are you the surgeon's patient? Are you the hospitalist's patient? Whose patient are you? Are you the ICU unit's patient? And often the surgeon is not really doing that great a job of coordinating your care and making sure that everybody who has a hand on you knows what's going on, because the surgeon is sort of running from patient to patient. So this has to be part of the way we change the way hospitals work, is that there needs to be somebody who's keeping track of what's going on, that everybody knows what's going on, and that, in fact, all the doctors are talking to each other if you're a complex case. I spent some time in a Manhattan hospital with a palliative care group, and palliative care is very, very important. Because they're very good at pain control, but they're also good at trying to get patients and physicians on the same page in terms of what is right for the patient. So this palliative care doctor actually, she had a case of a patient who was very complex. She had liver failure. She was an alcoholic. She, I think, had kidney cancer. Her kidneys were starting to fail. She had a whole series of things. She had pulmonary problems. And this palliative care doctor got 8 doctors into a room to talk about this patient. And what was fascinating was the doctors were having a hard time talking to each other. They were all talking over each other's heads. So the cardiologist was doing cardiology, and there were nurses in the room as well. So the cardiologist is doing cardiology speak, and the pulmonologist is using pulmonology speak, and the nephrologist is using nephrology speak, and they're almost deliberately trying to confuse each other because they're kind of one-upping each other. Mm-hmm. And the palliative care doctor was constantly getting them to re-explain in simpler terms what was going on. And then trying to get them to understand that this patient was not simply a collection of organs. She was a human being, and what they needed to do was help her understand what was happening to her and whether or not it was worth it to do, say, a catheterization on her, the cardiologist might want, or to put her on dialysis like the nephrologist might want. And to let her understand what it would really mean to make decisions to go through all of this stuff in what was very clearly her last few months of life. And it was quite extraordinary to watch.
Yeah, that holistic approach to healthcare is something that we tout in nursing curriculums, and I think nurses do a better job of being holistic in their care because they see the whole patient, and they are the ones that are with a hospitalized patient more than anyone else that they come in contact with. But that holistic approach to healthcare is a real challenge when you have so many different specialties that are trying to do the best for their particular arena, whether it's the patient's heart or the patient's liver or the patient's fractured hip. And they are very good at their individual expert areas. However, they don't see the whole picture often.
No, and also, even if they do, their voice is not quite as powerful within the hierarchy of the hospital as it probably should be. Mm-hmm. I'll tell you an interesting little story about that. A friend of mine told me about his mother, who was in the hospital, her mother, who was in the hospital and had chronic heart failure. congestive heart failure, so much that she could barely stand up out of a chair. So she was hospitalized because she was having one of those acute moments. And the cardiologist was saying, I want to put an ICD in your chest. I want to put an implantable defibrillator in. And the woman is going, okay, all right, that sounds like a good thing. Yes, it will make me live longer. It'll make it easier for me, et cetera, et cetera. And then the cardiologist leaves, and the nurse comes in, and she says, don't do it. She says, this is what this is really all about. This device will do X. You will be shocked if you go into arrhythmia. It really will not extend your life in an appreciable way. It will not make much of a difference in the quality of your life. You will have to recover from the procedure. Think about this carefully. And all of a sudden, the woman and her daughter went, oh. But it was very hard to fight the cardiologist, who really was saying no. And the cardiologist really wanted to help this woman. Mm-hmm. But he was forgetting that in the totality of her life, an extra few weeks or months might not be worthwhile. So the nurse had a very interesting role to play there, I think.
Yeah.
In sort of knowing the medicine and knowing this woman.
Yeah, you have to put all the parts together.
Mm-hmm.
So.
And some people are going to say, I want everything. I want you to give me everything. And we're a rich enough country, at least we were a year ago, then we should be able to say, okay, if that's what you really want, you can do that. But we should also be able to have patients who say, I don't want that, and be able to help them live however long they're going to live in a way that is right for them.
Yeah. Well, there are a tremendous amount of challenges ahead of us in this country to get our healthcare delivery system back in line or in a healthy form in itself. So I thank you so much for coming and sharing with us and spending a little time here at Grand Rapids Community College, and for the interesting and thought-provoking ideas that you have presented to us. Thanks so much.
Thank you for having me.